talk.
Thank you. Thank you guys so much for being here. I know you guys could be in a lot of other places, so I appreciate your time. So I'm not going to talk about my telomere work today, but if any of you guys are interested, I originally wanted to connect a lot of this stress work that I'm going to share with you today with my telomere work, but after digging into the HRS telomere length is just a mess, and I had to take a lot of steps back in order to really get at some of the questions that I think might be important moving forward with telomere length, which does not get me to my stress work. But if any of you guys want to talk about telomere length afterwards, or if you guys are particularly interested in it, I'm going to use the new telomere length data in the HRS that they're now re-assaying from blood. Which before they had done saliva. So I'm going to keep working with that. So if any of you guys are interested in talking about that, please let me know. So the title of my talk today is Stress Exposure Enough? Race, Ethnic Differences, and Chronic Stress Exposure, Appraisal, and Mental Health Among Older Adults. So I like to start my presentations here, one, because what's motivating a lot of my work is this Black differential in health and in the lifespan. And I like to think about what some of the unique difficulties minorities face in reaching older adulthood. But secondly, I like to show this slide because it facilitates a conversation around when and why we call something a paradox. And in this case, I'm referring to the Hispanic Paradox, which is this really overused idiom to describe the fact that all Latinos grouped together, including foreign-born, US-born Hispanics, including Puerto Ricans, Dominicans, Mexicans, Central Americans, all lumped together have longer lifespans relative to whites, despite having lower SES. So we refer to this as the Hispanic Paradox. And I'll get back to this point later, but I want to challenge this notion of calling things paradoxes when minority groups look better relative to whites in this country. So what is killing Blacks over the life course? The top four, actually, 3 of the top 4 are diseases of aging, so heart disease, cancer, and diabetes. And the 2 leading causes of death in the United States is heart disease and cancer, and they make up a huge portion of what Blacks are dying for earlier relative to whites. But a lot of the times the conversation really stops there. You know, we don't have more nuanced conversation about Black health. And there's a lot of places where Blacks actually look better than whites that don't get termed this paradox. But we risk losing some of this nuance by calling things paradoxes and not having more in-depth conversations around Black health. Now, some of these things where there are Black advantages, like Alzheimer's disease, that's more a result of mortality selection, and that Blacks aren't living long enough to get Alzheimer's disease. But things like suicide is something that we don't talk a lot about, but that is a clear paradox. So one of the better known or the sexier paradoxes that we've heard about is that despite having higher stress burdens, Blacks have lower rates of depression and anxiety. And we don't have good ideas for why this exists. There have been a couple of ideas thrown out, but none of that have been empirically tested at the population level. And I think part of the reason of labeling things a paradox and creating this notion that there are these paradoxes, we've not created good lines of research to underline why they exist and to explore some of the mechanisms that might lie behind these things, and thus don't create a level of conversation or research around places where Blacks look better, which might have a lot of implications for how we're thinking about and measuring health disparities at the population level, and that these places where we do find Blacks look better can provide some information about disparities that we're not getting from just a disadvantage framework that is often used in disparities work. So we have really great ideas to show why Blacks look worse over the life course, and that's primarily around stress frameworks. We predominantly use the stress exposure hypothesis, and that's that racial and ethnic minorities look worse on major health outcomes because they're exposed to greater stress. And then we double down on this, and we say where there are equal levels of stress, minorities react more strongly to stressors because more vulnerable groups have fewer resources social and personal resources that can be used to lessen the effects of stress on health. But this doesn't get us any closer to thinking about why some of these paradoxes exist. And our stress theory in general, I think, is really, our empirical and our stress theories is really lacking in helping us understand some of these places where Blacks look better. So how are we measuring stress at the population level? One of the reasons we may not be able to get at these paradoxes is by the shallow ways in which we have measured stress, especially in population health surveys. So typically we're measuring objective exposures to events, and it's like just a list, and people are checking off yes or no, do they have exposure to an event? And this is actually, Slavich wrote a paper called Stressnology recently, where he is staking claim that this really superficial measurement of stress is extremely problematic in how we're thinking about how it affects health outcomes. And he's playing off the idea that there was a line of science where people would look at the skull and be able to tell what your personality was. This was like in the 1800s. You could just look at the skull and know different parts. And that was termed phrenology. So he plays off this word, phrenology, to create stressnology, creating this underlying assumption that we have very shallow measures of stress that we're using to connect to health outcomes, and therefore really limiting the conversations we're able to have. So some of the limitations in measuring stress at the population level by just an objective exposure to an event is that we assume stress exposure has this very constrained time frame. So oftentimes we say, in the past 6 months has this happened, and we embed this really shallow idea about time frames into our stress measurement. On top of that, we assume stress is this very uniform experience, and that there's not this subjective or variability in how somebody perceives their stress, or the subjective component of stress. So this may matter for how we're thinking about the black-white mental health paradox. So the first limitation that I mentioned was that there was this aspect of time, and that we've kind of embedded these really shallow ideas about time into our stress measurement. And that's partly because it's just easier to measure certain time aspects of stress. We don't have good ways of modeling this chronic stress over time, and it's much more complicated to measure, especially at the population level. But most of the work we know that does involve chronic stress has been able to show that it's much more important for health and well-being than these acute forms of stress, and it kind of serves as this ambient background where you know the stress is embedded into your social environment and you're interacting with it daily, and that's what really raises your level of stress in the body, and it leads to this accelerated aging, this weathering hypothesis over time. The second limitation that I mentioned was that stress is measured objectively. Oop. There we go. So the second limitation that I mentioned was that stress is measured objectively, and that we're not capturing the subjective component of stress at the population level. And it's interesting that we have chosen to do that because even our earliest definitions of stress, so Lazarus and Folkman in 1984, said the degree to which a situation is perceived as threatening and elicits stress is a psychological process, a function of the individual's appraisals of that situation. And most of our stress models, even in later publications, say that it starts with this idea of perceived stress, but we're not capturing that well at the population level. So this might be really one of the keys to thinking about this difference in population levels of depression and anxiety. So does everyone really consider stress exposure stressful? From the psych-lit, we know that we know that there's a lot of variability in how people perceive stress, and that hasn't exactly translated well into this demography realm or the population sciences realm, where we're thinking about stress in the way that psych people might think about stress. And I think that's something we might want to think about in terms of these interdisciplinary conversations that we're having in the stress literature. So most studies they definitely don't consider if this perceived stressfulness, but they definitely don't consider systematic differences in perceived stressfulness. So why would we think that there might be race and ethnic differences in how somebody perceives a stressor? One aspect being that there are cultural and socioeconomic contexts that they provide frameworks for how stressful something might be. So the extent to which an event will be appraised as stressful is often influenced by your surroundings, your context. So stress isn't experienced in a vacuum. It's experienced in the context of a lot of personal and social resources. And there are race-specific protective resources that might even be important. So a lot of the literature would suggest that Blacks and Hispanics would be more reactive to stress based on the fact that they have less exposure to things to material resources like SES, education, income, and wealth. But there are a whole host of race-specific resources that might be utilized by these communities who have less access to financial resources that might work to buffer the effects of stress on health. So race really uniquely shapes exposure, it shapes appraisal, and then protective factors that may differentially impact mental and physical health outcomes. So what about aging? And how does this intersect with this literature? There's a lot less work done on chronic stress and aging. A lot of the work has been done in older adults in thinking about negative stimuli and responses to acute stress, and that's where we get this socio-emotional selectivity theory and the positivity effect that older adults are often reframing their stress and turning able to spend more time with positive stimuli rather than negative stimuli. But there's some research that suggests that older adults would have greater difficulties recovering from chronic stress just because it's this ambient background that they're exposed to and don't have the same choices they would potentially in acute stress to turn away from it, and they have less resources and often physical function limitations that would lead to more health damaging responses to chronic stress, making it an extremely important realm of stress work to focus on for aging populations. So my study aims today, we're going to talk about two of my papers. The first one is just using a more comprehensive measure of chronic stress in particular to examine race differences in both exposure and then the perceptions of these exposures. And we're going to look at these across different domains. And then in study two, we're going to connect both exposure and the perceptions of these exposures to anxiety and depressive symptoms in older adults. My data is from the Health and Retirement Study, which is a racially and socioeconomically diverse sample of older adults, and the HRS actually oversamples Blacks and Hispanics at a rate of 2-to-1. So we get a large enough Hispanic population to actually tease apart both US-born and foreign-born Hispanics, which give us a little bit more clue into the story around Hispanic groups. So my data are coming from the Leave Behind Questionnaire, which is a questionnaire that started in 2004 to collect information about life circumstances, subjective well-being, and it's collected every 2 years on a half of the sample from the core sample. But in 2006, they started measuring chronic stress, and the way they measured chronic stress is different than a lot of other studies have chosen to measure it. So they ask, in the last 12 months or longer, do you have ongoing health problems in yourself, physical or emotional problems in a spouse or a child, problems with alcohol or drug use in a family member, financial strain, housing problems, problems in a close relationship, or helping at least one sick, limited, frail family member on a regular basis. But what's unique about the question is that the respondents could choose 0, no, it didn't happen, 1, yes, it did happen, but it was not upsetting, 2, yes, it did happen and it was somewhat upsetting, or 3, yes, it did happen and it was very upsetting. So they kind of have combined an exposure and appraisal measure into one construct, and it operates very differently other people who have used this construct, it operates very differently than other measures of stress in the HRS. So what I did was I got to be a little creative with creating new stress measures where I'm just looking at exposure, which is simply a count of yes, no, did you have any of these stress exposures? And then I created a stress appraisal measure. So if you reported that yes, you did have any of these exposures, what was the average stress appraisal for these? So that's why the N is a little bit smaller, because you had to report a stressor to get into our stress appraisal group. Our mental health outcomes are our anxiety symptoms, and you have an average of 5 items. It's fear of the worst happening, being nervous, your hands trembling, fear of dying, or you felt faint. And respondents could choose never, hardly ever, some of the time, or most of the time. And then for depressive symptoms, it's the CESD. So it's just, is this true of much of the time during the past week? Did you feel depressed? Was everything an effort? Did you have restless sleep? Were you happy, lonely, enjoyed life, sad, couldn't get going? And the positive answers are reverse coded to create a count of depressive symptoms. So quickly, some of our sample characteristics. The mean age of the sample was 66.3, but respondents ranged from 52 to 104. Our race ethnic composition was 85% white, 9% black, and then US born and foreign born Hispanics were split at 3% each. And then gender breakdown, we had 54% female and 51% had a high school degree or less. Getting to some results from my first study. So this is published in the Journal of Gerontology Social Sciences. So looking at exposure, these are predicted probabilities from Poisson regression models. Just looking at 0 to 7 stress exposure, average stress exposure. So this isn't surprising. Blacks and US-born Hispanics and foreign-born Hispanics all report more stress exposure. And then when we add SES into the model, our Hispanic and white differences go away. But that's not true for our black group. I think here, SES seems to be a protective resource for our Hispanic groups, but consistent with the hypothesis of diminishing returns, SES is not as strong of a protective factor for blacks as it is for our US-born or foreign-born Hispanic groups. So when we break this down by domain, and look across all of our 5 domains, we're showing predicted probabilities of having exposure to any one of these domains. Health was the most prevalent domain, which makes a lot of sense because we're talking about older adults. But blacks and foreign-born Hispanics reported more exposure to health issues relative to whites. All of our minority groups reported more exposure to financial strain relative to whites. The same was true for residential strain. For relationship strain, we have blacks who are reporting more exposure, but US-born Hispanics who are reporting less. And then caregiving, there was an equal distribution across groups. But I want to highlight financial and residential strain. I think these represent spaces for public health efforts, spaces that show that there's this systemic level of oppression that's following older adults well into older ages. We have some respondents who are 104 who are reporting financial residential strain. I think these are places we have room to grow and things we should be focusing our efforts on for older minority communities, and potentially places we could improve the health and well-being of older minority communities. So then when we look at stress appraisal, did I mess that up? So then when we look at stress appraisal, despite having more exposure, so these models are controlling for the total number of stress exposure, that blacks and US-born Hispanics are reporting that they are less upset by chronic stress exposure. And then when we adjust for SES work and marital status, blacks have even larger differences from whites, and US-born Hispanics remain the same. This suggests that well-resourced blacks are even less upset by stress exposure than blacks who might have less access to resources. So I think it works a little bit differently than our exposure, that appraisal has a different relationship with race and SES, and that resources might be really protective mechanisms for blacks who are appraising their stress as less upsetting. I want to also note that one of the reviewers, when I submitted this paper, thought that there might be a reverse causality issue in that blacks or Hispanics or whites who had anxiety and depression might also be rating their stress as more upsetting, so we controlled for anxiety and depression and the results were stable. Yes?
Just to help maybe some others in the room who don't really know anything about stress measurement.
Sure.
I get here that these are significantly different, and the same was true in the count.
Yes, yeah.
Exposures.
Mm-hmm.
How big are these? How should we think about the scale? I don't
Yeah.
have any sense of what that seemingly small difference means, but it may be.
I think you can only interpret it in relationship to a health outcome, right? So, you know, I don't think talking in and of itself about the scale matters much just for thinking about how these differences might operate, but it's a beginning point to then connect these to later health outcomes to see if you know, this mean difference has any productive or something meaningful for the health and well-being of these communities, which is the next part. I'll definitely get there. So when we look across domains at stress appraisal, these are predicted probabilities of considering stress appraisal either somewhat or very upsetting versus considering it not upsetting at all. So you see that foreign-born Hispanics are more upset by health-related strains. For financial well-being, blacks are less upset by financial strain. There were no significant differences, but you can see that blacks are less upset and foreign-born Hispanics are less upset by residential strain. Relationship strain, all groups were less upset relative to whites. And then caregiving strain, blacks and foreign-born Hispanics were less upset. Foreign-born Hispanics basically don't think caregiving is a strain at all. They have very low levels of reporting being upset by caregiving strain relative to these other groups. And then when I control for all of our SES, wealth, marital, and employment status characteristics, blacks are less upset across every stress domain relative to whites. So I've been thinking a lot about why blacks would be, and minority groups in general, would be more exposed by stress but consider it less upsetting. One is, you know, an idea we've already talked about is these protective factors that racial and ethnic minority groups might be using to buffer the effects of stress, including things like religion, social support, or having strong racial or ethnic identity. Another is a hypothesis around aging, in that we're capturing stress for older adults, and it's chronic stress, so it's likely that these older adults have been experiencing this stress over a long period of time, and we're just nabbing them at one time, and they've been dealing with this for potentially a very long time, so they've learned how to cope with the stress, and it's no longer as upsetting as maybe it would have been in earlier periods of their life. Or it might be that minority groups are generally interpreting their stress differently. And the idea that stress is relative, or that you might learn stress from your families, may be important here, and that blacks are learning, or minority groups are learning how to adapt or deal with their stress from the people around them. And if everybody is similarly stressed, maybe you don't think about stress in the same way as other groups might think about the stress, or there may be less of an expectation to not be stressed. For these groups. It might also be that we're not measuring the stress that's important for racial and ethnic minority groups. So one of the questions for a relationship strain was, do you have a problem in a close relationship? You know, maybe we should be asking, do you have somebody in a close relationship who's incarcerated? And maybe we would be pulling out different responses if we were getting at certain types of stresses that were particular to minority groups or that were stressful to minority groups. And maybe this cross-section of stress is not the stress that bothers racial and ethnic minorities, so we're not picking up some of that upsetness when we're comparing them relative to whites. So some things to consider that we've learned from this study, that stress may not be universal across populations, and we may need to be thinking about fitting our stress measures to the needs of our population. Stress exposure and stress appraisal have very different relationships with race and ethnicity, and these constructs are different and they're measuring different things, and we might need to be thinking about that in our connecting these to health and well-being. So getting to the point is stress appraisal a productive means of reducing depression and anxiety symptoms? We want to see if this appraisal measure matters at all, or if it's just a benign activity that Blacks and Hispanics might be engaging in to say they're reducing their stress, but it's not actually manifesting in any health or in any health outcomes, or does it have an impact on health and well-being? So first, the first issue is that there are no BlackWhite paradox. There's no BlackWhite paradox in anxiety and depressive symptoms, and depending on how you capture anxiety and depression depends oftentimes on whether or not you get the BlackWhite paradox. Which there's a lot of very speculative research about, you know, whether we capture a diagnosis or whether we capture symptoms, and why we're capturing the paradox and using some measures but not others. None of which is the subject of this talk today, but there's a lot of really good work going on, including at the University of Michigan, in thinking about, especially in the HRS, how we're capturing depression and anxiety symptoms and why that matters with different race and ethnic groups. But in this case, anxiety, both Blacks report more anxiety and depressive symptoms relative to whites. So when we try to use stress exposure to predict anxiety, you see that stress exposure is consistently important all the way through to our interaction model, where we're interacting race, ethnicity with stress exposure. And when we look at that interaction, when that's graphed, you can see that at lower levels of stress exposure, there's fewer anxiety symptoms, but as we go up, there's a significant difference between Blacks and whites, where Blacks are reporting more anxiety symptoms with higher levels of stress exposure. And one of the reasons this might exist is because there are about 30% of Blacks who report 4 or more stress exposures, where there's only about 15% of whites who are reporting that they have 4 or more stress exposures. So a lot of that might just be captured in the fact that majority of Blacks are reporting higher stress exposure. And then when we looked at stress appraisal and its ability to predict anxiety, you see that it does predict anxiety independent of chronic stress exposure. The interaction between the two is not significant. So with appraisal, you can see with appraisal there's this kind of gradual increase in anxiety symptoms, but there's no significant difference between Blacks and whites, although it gets a little bit bigger when you get up to this very upsetting stage of appraisal. And then when we looked at depression, you can see that with exposure, similarly, chronic stress exposure is an important predictor of depression, but the interaction between race and exposure was not significant. So when we graphed this out, there's a similar increase in depressive symptoms between whites and Blacks. There's not much difference between the two. But then when we looked at appraisal, appraisal was independently predictive of depressive symptoms, and the interaction between appraisal and appraisal and race was significant. And graphing those, you see that when stress is not upsetting, Blacks and whites are reporting similar levels of depressive symptoms, but as stress gets more upsetting, there's a greater difference between the two, suggesting that these appraisal mechanisms might actually have an effect on the mental well-being of both groups, but definitely so for Blacks and definitely so for depression. And I think, why would we see this in depressive symptoms and not in anxiety symptoms? And that might be specific to the fact that we're measuring chronic stress, and that chronic stress often has a role component attached to it. That not being able to provide financially or having problems in close relationships may translate into more depressive symptoms, whereas anxiety is viewed more as an acute response to stress and not this kind of chronic ongoing response to stress. So we may be picking up this difference in depression just based on the fact that we're measuring chronic stress, but had we measured a different type of stress, maybe we would see it more in anxiety or vice versa. So a quick summary of our findings. Blacks and US-born Hispanics are reporting more stress exposure, but are generally less upset by this exposure relative to whites. Foreign-born Hispanics report more stress exposure, but rate their stress about as equally upsetting as whites do. Both chronic stress exposure and appraisal are important predictors of anxiety and depressive symptoms for older adults, where more exposure and higher appraisal are associated with more anxiety and depressive symptoms. And this appraisal process may be a productive way of reducing anxiety and depressive symptoms, especially for Blacks. So what are some of the implications of this work? For one, exposure is not enough. It really oversimplifies the stress experience. And I don't want to diminish the importance of the stress exposure literature. I think it has a lot of implications for how we're thinking about stress to start off with, but I think it's important that we start incorporating these measures of appraisal at the population level so we can have these more nuanced discussions about stress and how different groups may be reacting to it. The chronic stress experience is very different for racial ethnic minority groups in older adulthood, and we need to be thinking about that when we're measuring stress. Appraising stress as not upsetting may really have this buffering effect on health that we could be looking into in different capacities and thinking about measuring it in different ways. Reporting how upsetting you are is one way to do it, but there are a lot of other ways we could be capturing appraisal, thoughtful ways that we might be able to capture appraisal that might better the stress measurement and help us get at some of these ideas. So this work is innovative in that it's quantifying stress appraisal in race and ethnic minority groups, and we're able to compare across groups. And the domains give us a place to focus our efforts and how we might help reduce health disparities. And also may help us understand the black-white differences in the mental health paradox. So I am currently thinking and working on a new stress measure that captures both exposure and appraisal, and that might actually capture it better for racial and ethnic minorities. That's thinking about early life, current exposures, event-based exposures, chronic exposures, and then also specifically race-based stressors that might be really important for these groups. But my overall goal is to not assume that an exposure is similarly stressful across groups, that we can directly measure appraisal in contrast to a specific exposure so that they're connected. We have things like the perceived stress scale, which takes a very global approach to stress appraisal and doesn't allow you to tie it specifically to the type of exposure you're looking at. And I think that's a detriment in thinking about how we might aim to reduce or aim to improve public health efforts. And then I want to include exposures that, like I said, are salient for minority communities, including things like discrimination, incarceration, or early death of loved ones that may matter more for minority communities. And some of my future work, I'm going to look at mental health trajectories over time. Right now, this is cross-sectional work, but I think there's something to be said about the mental health trajectories of older adults over time and how that might relate to their chronic stress burdens. And thinking about better ways to model this time aspect of stress. So the HRS just recently got a life history survey, where they have collected data where you have, for every year of their life, if they had exposure to certain types of stressors, and you're able to model this time aspect across the earlier periods of their life. And a lot of the methods around this are using sequence analysis, which is originally developed for DNA sequencing, with the idea that every DNA sequence is different and each sequence can predict differences in health. So now we'll be able to use some of this new data to create a sequence of stress that's unique to each person and predict health outcomes. So this data is actually really exciting. I'm looking forward to working with it. And then thinking about the intersection of exposure and appraisal, it might not be that we should be measuring these things separately and considering them separately, that it's actually the interaction of exposure and appraisal and how those are working together that impact mental health and well-being. So thinking about the more dynamic aspect of the two that relate to well-being in later life. And what does this mean for physical health if we're able to model this appraisal process for mental health? Does it have the same effect for physical health, or is it benign for physical health? And then some of my future work in thinking about the epigenetic profiles of highly stressed Blacks who don't report any depression or anxiety symptoms is something that the HRS is just now getting some epigenetic profiles that I'm proposing to get training for through a K99 application. So a lot of my work, I want to focus on Black or minority advantages and not just have these stories of disadvantage around Black health. Having a more nuanced discussion about stress and stress exposure, I think, is one way to help get at that and have better conversations around minority health and well-being. I want to acknowledge my funding and my mentors, Jennifer Alshire, Eileen Crimmins, and Elizabeth Zielinski at the University of Southern California, and then one of my co-authors, Uchechi Mitchell, who's at the University of Illinois, Chicago. Thank you guys so much for your time. Questions? Yep. Therapy work.
About how this might apply my work with minority clients and like the balance between facilitating like the development of coping skills and like
Sure.
appraisal about the stressors that they experience, but also these multicultural models of therapy that involve like raising critical consciousness that might involve like exposure to distressing situations.
Mm-hmm. Yeah, that's a good question. I think I want to be careful in not suggesting that we should, instead of reducing exposure to stressors for minority communities, that we should be focusing on how they're appraising their stress rather than reducing the stress that's in their social environments. So I don't know how much we want to take on this idea that appraisal is a valid or a really great way to go about, reducing health disparities. I think it's a tool to understand the disparities that are currently existing, but I think helping Blacks reframe in the moment, or helping minority communities reframe in the moment, could be a productive strategy, but not one I would want to advocate for the entirety of our minority communities. And really, our outreach should focus more on this exposure idea, I would think.
Several sort of plausible explanations for the racial and ethnic differences in assessment relative to a specific exposure.
Mm-hmm.
Have you examined any of those, sort of like isolation, access to family support, you mentioned religion?
Yeah.
Most of those are in the HRS.
Yeah.
I'm curious if you've looked into that.
I looked at social support and religiosity and religious attendance, and they weren't explaining any of what's going on. And I think protective resources in general have not been a fruitful line of work. Don Muzan has done a lot of work in looking at protective resources to explain just directly the black-white mental health paradox, because that's been one of the hypotheses that have been floating around. And she's not been able to find much support for that hypothesis either, those aren't really the main underlying factors that are explaining some of these differences. Yeah.
Intersections between race and gender,
Yeah.
something did not happen, or that it's future work?
So I looked at race and gender, and the only thing I pulled out was that white women were the most stressed, but there were no differences between genders between any of these other groups. And actually, when I was going through the review process at Journals of Gerontology Social Sciences, one of the reviewers was kind of pushing that I take a white fragility approach to this work, which is the flip side of this, right? And it's one way to do it, and potentially a problematic way that's inflammatory, maybe even. But I chose to stick more with thinking about the minority stress experience and how their stress experience might be unique. So, anything else? Yep.
So the HRS has been going on for quite a number.
Yes. Yes.
See any differences in cohorts in their responses?
That's a good question. So unfortunately, the Leave Behind questionnaire is relatively new, and they have only measured chronic stress in the same sample 2 times so far. So they haven't done different groups of people to different cohorts for me to be able to get at cohort differences in this. But there are important age differences. So if I've only looked at exposure, but when you kind of divvy up the 70 and younger versus the 70 plus group, there are important exposure differences for minorities, especially for blacks who are reporting. So in general, people think stress exposure declines with age. That's been a predominant hypothesis in aging work, and it's true for whites, and generally true for Hispanics. But for blacks, they're reporting similar, if not more, stress exposure after 70 as they are before 70. And I haven't looked at that with some of this appraisal stuff, but I imagine there's an age component that might be going on as well there. Yep. Yeah. 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 Mm-hmm. Right. Yeah, I think it was last week. Yeah. Right. Mm-hmm. That's a great point. I know we're so constrained by what these studies measure in terms of mental health. When you have two mental health outcomes you can really be looking at. I think what might be important here is to think about things outside of depression and anxiety that get at mental health, like maybe hopelessness or like mastery or other psychosocial outcomes that have mental health implications that might be able to get at some of these differences as well, that don't rely on maybe a depressive or anxiety symptoms that we know aren't picking up all the things that we'd like to think we're picking up, especially in minority populations. So.
So I'm really fascinated by this talk. Thank you.
Of course.
One of the questions that I have is that one of the ideas that sort of flows through a lot of the analysis of disparities, whether they're racial disparities or socioeconomic disparities,
Mm-hmm.
stress is sort of this pathway between experiences of social disadvantage and
Yeah.
also sort of physical outcomes, including mortality.
Sure.
And so this finding that you have that in the realm of mental health
Mhm.
can't necessarily directly translate what we measured before as stress into
Yeah.
directly into the expected pathways for mental health. In what ways do you think what implications would that have for attempts to look at this relative to physical health outcomes in which we know that there are disparities?
Yeah. I think there might be this separation potentially between like exposure impacting you without this conscious process And maybe the conscious process matters in some ways, but that it doesn't matter in all ways, and just the exposure to your environment is inducing physical health disparities. But this conscious process might be a different pathway that we should be thinking about, that maybe the connection isn't as clear between the two. But yeah, I don't know. I think that that's a good place for this work to go, is to tease apart how mental and physical health disparities might be operating differently with the different aspects of stress experience. Yep.
In environmental studies, they try to understand how things like air pollution affect health.
Mm-hmm.
One of the concerns is that the most vulnerable people
Mm-hmm.
may take measures to avoid exposure to air pollution
Mm-hmm.
by staying inside or running their air conditioning more often.
Sure.
Is there any parallel thinking here where the people who think they are or know themselves to
Mm-hmm.
be the most vulnerable to
Yeah.
stress exposures take measures like job choices or other
Mm-hmm.
things that essentially move them away from stressful situations or stressful exposures?
Mm-hmm.
Then you might not be getting you may be underestimating in some sense the effect of stress in the situation.
Sure. So you're saying that you think that people who would normally experience a lot of exposures are somehow avoiding these exposures, and
If that's in their realm of choice, like
sure.
here's a job that might be more stressful, might pay a little more. Here's a job that's less stressful, doesn't
Mhm.
pay as much, but I know that I don't respond well to stress, so I may opt into the job.
Yeah. In that way, I think it would be important to get a better idea of these intersections of exposure and appraisal, like where these two are meeting for certain people, and how that intersection for people matters for their health and well-being. But in general, I think if we're thinking about chronic stress, the choice factor of it may be a lot different in terms of trying to subvert something like financial strain or economic strain, or caregiving burden or something like that. Your choices, I think, might be extremely limited. But yeah, that's a great point. I hadn't thought about that. Yep.
Does the Leave Behind survey have the feature like the standard HRS where you have both spouses?
Yes, yeah, you can get at spouse, yes, yeah.
So therefore, one might be a route for further extended
I don't,
social support.
yes.
Social support doesn't matter so far. It's
Mm-hmm.
a non-spousal measure.
Mm-hmm. Yeah, it is. It's an individual measure, exactly. Yeah, that's a good point. Could take in the spouse and their social support.
Because many times they might be reporting on the same stress and also
Yeah.
appraising them differently.
Yeah, actually looking at this in dyads would be really cool. You're right. Yeah.
I'd like, oh, sorry, go ahead.
Sorry.
In thinking about the adaptation
Yeah.
type of hypothesis,
Mm-hmm.
I know that you focus on older adults, but do you know whether we see that paradox in younger
Yeah.
minorities versus whites, where that would, like if younger people were upset by it, that might.
We see the paradox in mental health, but this specific research question hasn't been explored in younger populations, partly just because we have these measurement issues. And also the intersection of these literatures don't often go together. So people who look at appraisal are often looking in smaller samples or more racially homogeneous samples, and aren't interested in large population race and ethnic differences in how someone might appraise their stressfulness. So there's definitely room for that work to begin, but I don't know which data sets have the ability to really get at some of these exposure appraisal differences in younger groups. You had a question?
I was intrigued by the appraisal question, because most of the stress measures I've looked at just say, have yes, no
Yeah.
exposure.
Yeah.
So I'd just like your thoughts on how well the HRS measures capture
Appraisal.
differences, and what you would like to see if you were
Yeah.
had to next week decide what they were going
Right.
to questions.
Yeah, I mean, just asking how upset you are by a stress exposure, I think, is probably not capturing all of what I think this hints at the fact that we have a lot more work to do and that we have some appraisal processes that we need to be thinking about how we can better capture them. How we go about doing that, I've looked at the perceived stress scale, which hasn't been particularly useful because it just asks things about like how often you felt stressed. It's more of like a time aspect of this stress process. So yeah, I've had a lot of trouble finding other measures of appraisal that I think would capture this at the population level, but that's also easy to measure, right? Too, on top of it, it can't be super laborious for these participants to be. Yeah, no, I mean, if you have ideas, I would love to hear them. If any of you guys have ideas about how we might think about appraisal processes at the population level and what type of questions might get at this appraisal process, I think there's some room for us to, I would love to put a module in the HRS, an experimental module, and try to get at some of this appraisal a little bit better. Yeah.
Did I understand correctly that you said social support differences didn't seem to make?
They didn't explain the differences in appraisal. Yeah, the race differences. Their social support might be beneficial for appraisal processes more broadly, but they're not explaining the race differences in appraisal. Yeah. Anything else? Thank you, guys.